Don't wake people up from their nightmares. About 70% of adults will get exposed to trauma in their lifetime. About 10% of those meet criteria for PTSD. We can address and treat trauma in 5 sessions. It doesn't matter how long it's been. My record is like 65 years since trauma I treated.
PTSD is actually treatable. Nightmares are treatable. Sleep is not a luxury. It is part of healing.
So the good news is,
hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. For those of us listening here, Dr. Courtney Worley actually just returned from a vacation in Iceland. Courtney, you mentioned it was 23 hours of daylight. Right? That's stuff you see in movies, but you don't even know what it really does. How did you combat that for your sleep? How did you try to maintain some kind of circadian normalcy?
Absolutely. What does a behavioral sleep medicine psychologist pack for 23 hours of daylight? A really good sleep mask. That's the primary. And then, trying to stay on a schedule. The first time we went a number of years ago, we found ourselves hiking at 10:45 at night because it was still felt like daytime. So being mindful of trying to get on the schedule there once we got there. Anytime I'm recommending travel that crosses a couple of time zones, I'm always telling people, once you get there, try to get on the new schedule as soon as possible with meals and your light exposure. Light exposure in this case was not what I wanted. So making sure most of the places have good blackout curtains. But I still needed my trusty sleep mask most nights, and then making sure we were cutting off our activities. So I still got an opportunity for sleep every night.
When you had that opportunity, did you find that it was actually successful because you do these different things with the sleep mask and everything?
I think so. The first day, of course, is always more difficult for jet lag and everything. And adjusting, it was plus 5 hours. So that was a little challenging. But once I got there, yes. And today, I very much was up very early before I wanted to be adjusting back, but made sure to get my exposure to sunlight today. Went outside on a break and working on trying to get meals back on the right time to work with my circadian.
And Courtney was super active. She did a lot of hiking and touring, and that's the kind of thing you want to be doing on vacation. Yeah, you can relax, but try to make it still physically active. It's so great when you can do that too. That always helps with our circadian health. Awesome. Okay, well, that's a little segue clip, but anywho, now getting back to the show. Welcome again to Sleep is My Waking Passion. I have Dr. Courtney Worley here. I'm bringing her back because she is an expert not only in nightmares, but also in post-traumatic stress disorder, PTSD. And if you have started this episode at 3:14 in the morning, bracing, I hope you're leaving it with one more name, one more tool, and one more reason to believe your nights can look different. It turns out PTSD is actually treatable. Nightmares are treatable. Sleep is not a luxury. It is part of healing. And thank you, Courtney. She happens to be a board-certified clinical psychologist and diplomat in behavioral sleep medicine. She specializes in evidence-based treatments, not only for nightmares and PTSD, but also for insomnia. And I'm so glad that you're coming back on the show. She is actually this is part 2. So if you haven't checked out part 1, check that out. I specifically wanted her to speak with me again. Number 1, we had an amazing convo, so I wanted to continue it. And number 2, June is PTSD Awareness Month. And this episode will have launched in June of 2026, but we're going to make sure that we're doing something different for the show where we're cataloging the different types of programs that we have here, and yours is going to go into that bucket where people can more easily find you. And today we're going to be talking about what actually works, the evidence-based behavioral therapies that can give people their nights and their nervous systems back. We'll cover what PTSD really is versus how the word gets used in everyday conversation, and why sleep is so often the first system to break and the last to heal. And what are the frontline therapies that the Veterans Affairs, the VA system, and the National Center for PTSD endorse, and what therapists in the audience need to know about delivering these protocols as well. So, Courtney, Can you explain in plain language what PTSD is clinically, and how does this differ from the way it gets used in everyday conversation? Because I think this distinction is very relevant, and people need to understand that using it too loosely may shift the discourse. There's only so many of you to go around, and there's people who really need your services. So how do we differentiate the folklore on TikTok versus what is real?
I think just starting out with mental health and social media, we see so many things. And one of the things that I often talk to people about is those really brief clips are telling you what it could be. One of my roles as a board certified clinical psychologist is to also consider what else it could be and what it couldn't be. So it's not just about the inclusion criteria, but it's also exclusion criteria. And when I think about trauma is this thing that is widespread, right? About 70% of adults will get exposed to trauma in their lifetime. But about 10% of those, somewhere between 6 and 7% of the population, will actually meet criteria for PTSD. So trauma is incredibly common. PTSD is common, but not as common. And so when I think about diagnosing PTSD, I'm first looking for what we call a Criterion A trauma. That's under DSM-5, our Diagnostic and Statistical Manual that we use. Criterion A traumas involve actual or threatened death, serious injury, or sexual violence. It could be something the person has been exposed to, witnesses, or even sometimes learns about happening to a close family member or friend, or as part of their job. And that's where I end up seeing some healthcare workers, some journalists as part of my clinical practice, because sometimes that repeated exposure, even if it didn't happen to you necessarily directly, can create those challenges. So we have exposure to trauma. Trauma is different than stressful life experiences. Not saying that those things don't need to be treated. We just have different treatments for those, because PTSD requires specific treatments to address the neurobiology, right? The changes in the body and the brain and the alarm system that we all have. And so we look at the exposure to trauma, and then some resulting symptoms. We have things like unwanted memories, thoughts, and emotions, including coming up in nightmares and dreams. We have feeling like the event is happening again. Those are all part of what we call intrusion or re-experiencing symptoms. We also look for avoidance. Avoidance is not just a symptom of PTSD, it's also something that really perpetuates the disorder. So trying to avoid internal sensations, thoughts, memories, trying to avoid external cues for the trauma that they've experienced. And then we have what we call the negative alterations in cognitions and mood clusters. So changes in the way I think about myself, other people, and the world, oftentimes related to safety or trust, strong negative emotions, and then arousal and reactivity. That's that being on guard, alert, irritable, and anxious. And that's also where another sleep component comes in, oftentimes the insomnia component. So within PTSD, there are kind of two opportunities for sleep disruption in our diagnostic criteria. So we've got criterion A, and then we've got these other symptoms. We may have PTSD, but the thing is, a lot of people experience these symptoms immediately following a traumatic event, but they'll have what we call a natural recovery, where those symptoms will fade out over time. If those symptoms don't fade out because of largely avoidance and unhelpful thoughts and beliefs, that's where we go on to diagnose PTSD and to think about what evidence-based treatments we should apply.
And what signs should listeners is there a duration, for example, for the acute insomnia component when you're exposed to the trauma? What signs should the listeners be looking out for that may show up that kind of tell them? Is there a timeline? Is it you haven't gotten better in a year? How patient do they need to be before they seek out help?
Don't wait a year. No, don't wait a year. Please come in. We usually think about symptoms of lasting about a month, that most people will see that within 3 months. Certainly we'll see those symptoms drop off in people who have a natural recovery. So if it's been a week, hang in there. Lots of times things do resolve. People have that natural capacity, but some people have that natural recovery blocked. So the good news is, because PTSD is a problem in recovery, it doesn't matter how long it's been, you can still go back and have that recovery, still have that capacity for recovery. We just have to address the things that get blocked. I think my record is like 65 years since trauma. I've treated some very advanced age, older adults who are, in their 80s or 90s, and had trauma back in their teens or 20s, oftentimes military related, World War II, Korean era veterans, and they get better, which is a really powerful thing to watch.
Wow. Okay. So folks, pause, listen, think about people, either yourself or someone that you know, because we all know vets. I'm referring to them specifically because they're fairly classic, but if you know there's folks in your life that you suspect whatever happened to them is leading them to have a lot of struggles and contribute, there is hope even in that situation. I had no idea that it could be that effective that far out. That's amazing.
It's never too early and it's never too late is what I always say.
Wow. Okay. So it sounds like in the acute period, honestly, I'm kind of thinking about myself and like how long it took me to kind of finally sleep normally, I should say. So that 1 to 3 months, we typically say if we have an insomniac and we're classifying them, right? We might notice, oh, you have a trigger. They may come in, maybe it is about a month. How should I be looking at that case and maybe just doing simple, just making sure that they're not extending their time in bed or doing some maladaptive behaviors that we would do in cognitive behavioral therapy? And then kind of seeing them closely and seeing how they do, how their symptoms evolve maybe. Is that the better play as opposed to, because if you think about it, like they wouldn't have even entered into the chronic insomnia piece because they wouldn't have reached that 3-month threshold. For clinicians listening, I'm curious.
So I think if somebody's coming in that early and reporting signs and symptoms, then that's probably a good place for some early intervention. And to think about where we can start to make some changes. So if we're thinking about insomnia related to PTSD, that's where we might think about monitoring time in bed, doing some of those early interventions. If we're talking about nightmares, for example. So in the trauma processing model of nightmares, we know that the dreams and nightmares are normal. Most adults have had a nightmare in their life and many people in the last year. But if they're frequent, if they're persistent, if they're disrupting sleep, then we want to think about addressing it, because the trauma processing theory of nightmares says that our brain is kind of working to try to make sense out of and store away that information related to trauma, right? To process the memory, store it away, to reduce the emotionality, but it continues to get disrupted by nightmares, by awakenings. And so our brain kind of can't process that all the way through and store it. So it's also less effective oftentimes while we're asleep, because that logical, rational part of our brain, our prefrontal cortex, is offline, can't give feedback to the larger system that's active. And so doing some work during the day can be helpful. I think I highlighted avoidance a few minutes ago, and that's one of the big things that I pay attention to is, are people avoiding? It makes sense. Mm-hmm. You don't want to think about horrible things that have happened to you. You don't want to deal with these things, but the more we can approach it, the better the brain can process it during the day. Receiving social support, talking it out can really help with that natural recovery. But if it's been more than a couple of months, or it's really causing a lot of distress and impairment in somebody's life, then I certainly would start intervention much earlier. And I know we're going to talk about it, but one of the things that I think about a lot is intervention for what? Are we treating PTSD, or are we treating the sleep complaint, and in which order?
And so that's where your level of expertise can come in. So if a person is coming and they're talking to their primary care provider, for example, what would you want a primary care provider to know in terms of what they should be doing next? Because it gets into this gray zone of, here's a sleep aid and antidepressant. Like sometimes we don't know. It's hard to know what to do.
So I would encourage primary care doctors to befriend a sleep specialist. Have your psychologist or behavioral sleep medicine professional on speed dial. And in some cases, they already do this. Or some cases, there are behavioral sleep medicine clinicians embedded in primary care, especially in larger healthcare systems. But the best treatment is one that's evidence-based and the patient is willing to do. So one, giving that message that treatment is possible. Most people who have nightmares will not report to a provider, to a healthcare provider, that they have nightmares because they don't think nightmares can be done and anything can be done to treat them. Most people think nightmares are just something that I have, or it's just something I have to live with. So they may not even bring it up to their primary care provider. So step 2 after befriending a behavioral sleep medicine specialist is to ask. Ask about bad dreams, ask about nightmares, ask about sleep in general, because sleep is a foundational pillar of health. And so if we're asking people about their sleep, then we can help to say, and there are options available. There are not enough of us behavioral sleep medicine specialists out there, and that's one of the reasons why Dr. Michael Nadorf and I wrote the Nightmare and Sleep Disorder Toolkit, because we wanted people to have access to all of the things that we do in our clinic in a workbook that they could pick up and use on their own. And so that's another thing that oftentimes we'll see other health professionals having a copy or having a recommendation for those kind of online resources or a book to buy so that people can start to target that on their own. So I think asking is one of the most important parts so that you can let somebody know treatment is available. We can help with this.
I think just the fact that treatment is available is something that is mind-blowing to a lot of the medical community. I think it's something that we've all sort of been like, what can we do? And it's really reassuring to know that you've been in the trenches doing this work. Speaking of what we can actually do about it, you specifically mentioned to me written exposure therapy. I'm going to kind of put the floor to you. Maybe we want to start with that because I know that was very important for you to touch base, but I would love to know what kind of interventions are out there that behavioral therapists do.
Absolutely. So when we think about evidence-based psychotherapies for PTSD, our clinical practice guidelines from a lot of different sources, the VA/DoD has a clinical practice guideline, the APA has a clinical practice guideline, the International Society for Traumatic Stress Studies has a clinical practice guideline. Probably not surprisingly, they all say roughly the same thing in terms of recommendations for evidence-based treatments for PTSD. And so I think about written exposure therapy, cognitive processing therapy, and prolonged exposure therapy. Those are the 3 that I use most often as a clinician. They're also the ones that I teach and train other clinicians in. So I'm a national trainer and consultant for cognitive processing therapy and written exposure therapy. They all take on that idea that PTSD is a problem in recovery, and it comes from avoidance and unhelpful thoughts and beliefs that show up. And so I think of them as very similar paths to the same outcome, but we kind of have different entry points. So sometimes I talk about it with patients as, we're all trying to go up this path to the mountain, and you can start on the left, the right, or the center, and we'll all get there that same way. So written exposure therapy is a really brief intervention. It's usually 5 sessions, which is amazing to think about that we can address and treat trauma in 5 sessions. It involves what we call imaginal exposure. And all of the interventions for PTSD are going to have some kind of exposure component, exposure to the trauma memory, the thoughts, the emotions about it. Written exposure therapy has individuals to focus on writing about their experience. We focus in on one trauma and have them to write about it in great detail with thoughts and feelings, and all of the work happens in session, which is really appealing for a lot of people who don't want to do between session practice, maybe have other barriers to doing that. And so we use this idea of imaginal exposure, that is approaching the content, thinking through it, and then over time, this change in the way that people think about themselves, others, and the world, and the way they think about their trauma memory. And it becomes kind of stored as a memory, as opposed to feeling like it's happening right now, which is true for a lot of trauma survivors.
Does the written word, the act of putting the thought onto paper, is that connection through neuroscience kind of the secret sauce? Is there something about doing that allows the shift from the acute feeling to more of a memory?
Yeah, I think that works in a couple of different ways. We know that there are kind of these changes that happen neurobiologically when we go from thinking about something to saying it out loud or to writing it. It helps us to process. It also keeps that prefrontal cortex engaged. There's some debate And, my friends and colleagues are doing a lot of this work trying to understand what is the mechanism of action. Because one of the things that we think is probably there's a difference in mechanism of action between how written exposure works versus cognitive processing therapy versus prolonged exposure, but they all probably share some commonalities. One of the things that's showing up in written exposure therapy that actually comes from the world of OCD treatment is that they're this inhibitory learning model, that part of the process is in getting new information into the brain. Because one of the things that often happens is people tell their trauma story and they actually stop and think about it and put it all together. We're not doing memory recovery, but sometimes they're able to think about it in a different way when they think it through from beginning, middle, and end. And sometimes people go, I look for that moment that where I didn't recognize this before, or I didn't think about the fact that, my attacker outweighed me by 50 pounds and 6 inches, and I really didn't have a whole lot of options at the time, right? And so lots of times people are struggling with that idea of power and control, that they're kind of going back and forth, but it's so painful they don't want to think about it. So they don't ever think about it in enough detail to kind of see the full picture.
Wow. Can this be done remotely? Is this an option, written exposure therapy done digitally?
My entire practice right now is virtual. Yes. So, and for the last roughly 8 years, I've been training clinicians to do this in video telehealth. Yeah. And we have good research evidence to support that there's no difference in outcome when we compare in-person delivery versus telehealth delivery.
Oh my goodness. I mean, talk about access issues. Wow. And forgive me if we talked about it on our first session, because I just don't remember, because we've had a gap. For behavioral psychologists, can they practice in multiple states? Like for me, I have to get an individual license in like every state.
Currently for psychologists, some of the other disciplines are working on it, but I'm licensed in 43 states right now through our SIPAC and our jurisdictional compact. So I absolutely see people across the United States through my private practice and Upward Behavioral Health. And then, some of the work I also do, though I'm not here representing the VA, has been in the VA system. And I see people across the United States that way as well. So absolutely telehealth delivery, it works. It has a lot of advantages. It may not be for everyone, so we still want to give people choices for in-person versus telehealth delivery, but absolutely, there's been a lot of research, not just supporting written exposure therapy, but also cognitive processing therapy and prolonged exposure therapy. They actually have evidence going much further back because they've been widely trained for more years, but there's a lot of support for evidence-based treatments delivered via telehealth.
So speaking of cognitive processing theory, I'd love to know, because you are the expert, you helped create, I think it's called Cognitive Processing Therapy Coach 2.0. I would love to know, first of all, what is CPT? And tell us a little bit about this app.
Sure. CPT is cognitive processing therapy. It's an evidence-based treatment for PTSD. When I think about the two pieces of avoidance versus unhelpful thoughts and beliefs, I tend to say that CPT leans a little heavier on the unhelpful thoughts and beliefs. And so what we do is we help people to find stuck points. That is thinking errors or places where they've overgeneralized their thinking. And so let me give you an example. After going through trauma, people might start to feel like the world is a dangerous place. So they're adjusting their worldview based on their experience. And that's probably helpful, but people often go too far. And so it feels like the entire world is a dangerous place. I can't even leave my house. Or it feels like other people are always out to harm me, which might create some difficulty with close relationships, with trust, with intimacy. And so we have people to approach their thoughts. We catch them, we check them out, we give people tools to kind of explore and challenge what they're thinking, what's helpful, is there evidence for and against this, and to come to a more balanced view that really fits in their life today. It's usually about 12 sessions, and it has two different versions. One is cognitive processing therapy with the account, and the other is cognitive processing therapy without the account, meaning that at a point in therapy after session 3 and after session 4, we have people to write about their trauma in a detailed way. Without the account, we just talk about it in session. So there's still that approach of content that's key. But some people really find that the writing piece is helpful, and some people say, that's not my approach. We know that people end up in the same place in terms of recovery when the clinical trials have compared with and without. So we give people a choice. And cognitive processing therapy has been shown to be incredibly effective with lots of different types of trauma, with different people from different types of backgrounds. It's been done internationally. It is really an effective treatment for trauma. It's one of my favorites to do and to teach and to train. And then I could talk about cognitive processing therapy, or CPT coach, but I'm going to pause for a moment just to see if you had any follow-up about CPT as a whole.
It seems as though the written exposure therapy part is sort of incorporated into the written session of CPT. How are they distinct?
That's a great question. We talked a little bit before. We're still trying to figure that out in that mechanism of action, kind of dismantling type studies. But what we know, cognitive processing therapy and written exposure therapy have been compared in what's called a non-inferiority study, and they had equal outcomes. One of the things that sometimes gives written exposure therapy a bit of an advantage is people are less likely to drop out because it's 5 sessions.
Shorter. Got it.
Cognitive processing therapy spends more time on really examining and challenging some of the unhelpful beliefs that have developed after trauma. Writing is a part of it, but it's not as big of a part of it. In written exposure therapy, we write about trauma or the impact of trauma in every single session. It's really 30 minutes of every 50-minute session is writing. In cognitive processing therapy, there's a greater focus on examining and challenging some of those beliefs. So it's 2 different pathways to the same outcome in terms of recovery.
Yeah. That's really helpful. Talk to me. CPT Coach 2.0.
So as you are aware, there are a lot of apps out there, a lot of mental health apps that I kind of think of as a buyer beware situation, because you can look at and see some of the background information about how it's developed, how it uses your information. And so I've worked with the National Center for PTSD mobile apps team on CPT Coach. I was invited to be a subject matter expert there. And so we look at CPT Coach as a treatment companion app. So we have 2 different types of apps. Usually we have kind of the self-management apps. One of my favorites is PTSD Coach. That's freely available for anybody to download. It's in multiple languages at this point. It's something that somebody can just pick up and start using on their own. CPT Coach is a treatment companion app, meaning it's designed to be a supplement when people are enrolled in treatment with a therapist. So it has all of the materials that I would share with a patient in paper form or in an electronic fillable form, but it's just contained on their phone. All of the readings, all of the worksheets that we use. It even lets people do their assessments, their PCL, the post-traumatic stress disorder checklist, which is one of the measurement-based care tools that we use. One of the things I really like about the phone is because we're always encouraging people to use their worksheets, to be challenging some of these thoughts in real life. It's easy and discreet to kind of pull out your phone and work on it when you're at a family gathering, when you're at work. So it's easier than, having your workbook that you're trying to work on to remember everything until you get home. Some people just really also prefer a mobile solution. Sometimes it's better for privacy because they can lock their phone, whereas their therapy notebook might be at home and other people might see it if they have roommates or other people in their lives. So it just gives another option, and then we can continue the use of it after therapy is over. And so there's a place in the app to kind of switch over from I'm actively working in treatment to I'm graduated in CPT and I'm continuing to work on myself.
That's so cool and so useful. Very practical. Prolonged exposure therapy. You mentioned one more therapy. Tell me about this.
Prolonged exposure therapy has, I think at this point, it's 35 years of research supporting it. It really attacks PTSD from the avoidance piece. So it has 2 different components. After we do psychoeducation, which all of these start out with a rationale. Why would we ask you to do these things? Here's how it's going to treat PTSD. And then after prolonged exposure, we use what's called in vivo exposure and imaginal exposure. In vivo is in real life. So we're looking at situations that people have started to or continue to avoid because it reminds them of the trauma in some way. We work in therapy on building what's called an exposure hierarchy, which would be familiar to people who do just general anxiety treatment. What are some of the situations that are difficult for you to engage in or that you get that urge to avoid? What are some things that you've just stopped doing because you're dealing with PTSD symptoms? And then we rank those. We say, on a scale of 0 to 100, how difficult would it be for you to do this? And then we assign some of those, starting with easier exposures and working our way up to help people confront and take back those areas of their life that the PTSD has been encouraging them to avoid. And then the second part is imaginal exposure, which is where we teach people to revisit their memory and we have them to recount it out loud in session repeatedly. And then we actually make tapes for them to listen to between sessions. And so they'll listen to those as well. And it really, over this repetition, helps the brain to process and store away traumatic memories. Again, so that it's a memory rather than in PTSD, those symptoms feel like they're happening all over again with that fight or flight reaction. And it's usually between 8 and 15 sessions. All of these are done weekly or more frequently. So the good news about that is we can get a course of treatment done in a very short amount of time. And there's some evidence coming out to suggest that if we do what we call masked treatment, where we're meeting with somebody twice a week, 3 times a week, and really working through those therapy sessions, that the results may be even more effective than weekly sessions.
Speaking of success rates, what are we looking at across these therapies? What can people potentially expect? Sometimes they want numbers, you know what I mean?
Absolutely. And so one thing that I would encourage is there's this website called the PTSD Treatment Decision Aid, which is an amazing website. It just got revamped and it has a lot of information about all of these treatments that I'm talking about. And it lets people kind of go in and investigate and think about what treatment might be best for them. And then they can take that information to a provider. We think about 2 things. We think about reduction in symptoms. And then sometimes we talk about loss of diagnosis, where people fully not meet criteria anymore for those disorders. And so we'll see kind of different results sometimes across different populations. But my experience has been that these treatments are incredibly effective. 60, 70, 80% see a reduction in symptoms, which that sounds both high and low, because we think about if we take that over to the medical model, and what are you willing to undergo surgery for? 50% chance, I think, with bypass, right? And so we see these really big changes in people's quality of life. And so we measure a couple of different outcomes. We measure PTSD symptom reduction. We also measure functional changes. And so are you able to do the things that you want to do again? How are your relationships looking? So it really becomes about personalized goals.
So in the end, it's kind of helping you reclaim your life back, and that's sort of priceless.
Yeah, absolutely.
Do any techniques have any appropriateness for people who may have post-pandemic service level trauma? Do you work with healthcare providers? And have you any observations related specifically to them?
Yeah, I work a lot with healthcare providers, physicians, nurses, respiratory therapists, also other therapists, other mental health therapists. I see a good bit in my practice because the helpers need help too, right? And we absolutely see application for medical related traumas. If you're having these exposure to actual or threatened death, serious injury, sexual violence, but also just the repetitive nature of being exposed. I mentioned earlier, exposure to details is part of your job. And I mentioned journalists, or we could talk about police officers who have to watch footage over and over again that's really aversive. Well, our medical community sees things over and over again that are really aversive. And so absolutely we can see effectiveness. And there's some research, especially with CPT, cognitive processing therapy, looking at broader applications to cognitive processing therapy beyond just criterion A, trauma. The other thing that I think is important to mention that all of these that I've been talking about are cognitive behavioral therapies. So we think about cognitive behavioral therapy as a big umbrella term. And then we have cognitive behavioral therapy for insomnia, which I know you're very familiar with, and many of your listeners will be. Cognitive behavioral therapy for PTSD, which are some of these treatments we've been talking about. We also do for depression, for anxiety. And so they will have some of the same components that you would see across cognitive behavioral therapies for other interventions. And so sometimes we think about the applicability beyond PTSD.
All right, I've got 2 more questions for you. So my first one is, what do you wish more partners, parents, and family members understood about supporting a trauma survivor's sleep?
Don't wake people up from their nightmares. That one comes to mind because I have a lot of people who will say, they may or may not be reporting nightmares to me, or they'll say, I think I'm having nightmares. Well, how do you know? And they'll do, well, my spouse tells me the next day. Well, we think about nightmares as disturbing dreams that cause awakening with well-remembered content. If they're not having that, there may be something else going on. We also know that sleeping through a nightmare, sleeping through a disturbing dream facilitates that processing. And so it may speed recovery. The more disrupted somebody's sleep is, the worse they're going to feel the next day. We know that people who have disruptions in sleep tend to view the world as a more hostile and aggressive place. And you think about people who are already struggling with concerns for safety, trust, power control, esteem, and intimacy as part of PTSD. We don't want to do anything to add to that. We want people to be able to regulate their emotions better and to process their experiences better. And so letting people sleep if they can, I think is an important thing. But also, again, the message is treatment is available. And people often suffer for a very long time when we can often get really good outcomes in somewhere between a month and a half and 3 months of treatment. So it's a shorter term investment for a really long-term payoff in terms of quality of life.
Thank you for that. Final question. If you could retire one myth the public believes about PTSD and sleep, what would it be and what would you replace it with?
I want to do 2 parts. One myth that I would challenge about PTSD is that it is only a disorder from military combat, or that it's only something that happens to people who have been involved in a line of exposure to violence. It absolutely can be, but trauma exposure comes from a lot of different things. The number one reason for PTSD, or the most common trauma-related problem for PTSD, is motor vehicle accidents. And so people have PTSD for a lot of different reasons. It affects people from all walks of life, and it's treatable. We, in research studies, look at people with all types of trauma from all walks of life, and we find that everybody can get better. So that recovery is possible. I think something we didn't talk as much about today, but probably across the 2 episodes will come through, is this idea of you either treat the PTSD or the sleep. And that's a question that I get asked a lot is, which should I treat first? This is an empirical question that I would love to do a randomized controlled trial for. So if anybody has funding in a population, call me. But we haven't done that. That empirical work is not there yet to say which way we should structure treatment. And so for some people, we think about doing the sleep treatment first, because if we treat the sleep, maybe the PTSD will resolve or come down, or we need to get people sleeping enough that they can do the cognitive work of PTSD. Some people will argue that you have to treat the PTSD first, and if you do, the sleep problems will resolve. But we know that's not true from the research literature and from our experience. The 2 things that persist even after a successful course of treatment for PTSD is the sleep disruption and anger. And so I really think about this idea of the best treatment as the one that the patient is willing to do. And so when somebody comes in to me that has sleep problems and PTSD, I present all the options and I say, which one do you want to start with? Where would you like to start? And then we'll reevaluate, because maybe treating one does address both. And then if I get a bonus one, it's that medication is not the only solution. And in fact, in clinical practice guidelines, medications are a secondary recommendation with evidence-based treatments for insomnia being the gold standard from the AASM, for nightmares, mood rehearsal therapy is the gold standard, and for PTSD, evidence-based treatments for psychotherapy are the gold standard. So think about the options.
Wow. I'm so excited for this, just these 2 episodes that we've done together, because I've learned a lot, and I know people who are listening, we're seeing these people in our practice all the time. Now we have a way to give them tools and give them advice in a way that's actually actionable and helpful, because we're learning a little bit about what we do know. I mean, I know you live it and you eat, breathe, and do this all the time, but I got to tell you, for folks that are on the other side who don't, one of the biggest gifts I've had moving away from purely pulmonary critical care sleep pathway is interacting with a lot more healthcare providers that are on the behavioral health side of things. And it's really expanded my mind, because sleep is so intimately tied into what's going on with us emotionally. And I really appreciate you sharing your time, not once, but twice with me. So final words are, if this episode helps you understand someone you love a little better, or yourself, please share it. Tag me and Courtney, leave a rating. That's how we get this information into the ears of the people who need it most. Courtney, you have a lot of exciting things coming up. Please take it away. Share with people how they can work with you, what new books potentially and collaborations you're up to.
Sure. So people can find me at Upward Behavioral Health, and we are available for telehealth through 43 states right now in the United States. Do not have an international license. I do consultation and training internationally, but right now don't see patients for care internationally. But there are a lot of good providers out there. Receive evidence-based treatments for PTSD, insomnia, or nightmares. Apparently October is the month for books for me. So last October, the Nightmare and Sleep Disorder Toolkit came out. It is a self-help type guide for individuals who are struggling with their sleep and nightmares. Good for patients, for loved ones who are trying to understand, and for clinicians who want to deliver the treatment or just want to have a resource. And then this October, I have a new book that's more academic, more clinician focused on nightmares and nightmare disorder through Hogriff's Advanced Evidence-Based Practice series. And have a couple of webinars coming up that I'll be doing. So some CE offerings and some conference presentations that people can find at my website, drcourtneyworley.com, if they're interested, or on my Instagram at Dr. Worley Consult.
Thank you so much.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.